And welcome to this PrecisCa breast mini tumor board on breast cancer. My name is Dr. Reshma Matani, and I'm a breast medical oncologist and an associate professor of medicine at Sylvester Cancer Center, University of Miami, where I co-lead the breast cancer program. It's my good fortune today to be joined by several well-renowned experts in breast cancer, who I will now ask to introduce themselves. Dr. Buchholz.
Hi, my name is Tom Buchholz. I'm a radiation oncologist, professor emeritus at MD Anderson Cancer Center in Houston. I'm the medical director of Scripps MD Anderson Center in San Diego.
Terry Bauman is a breast surgical oncologist. I direct the breast cancer program at the Orlando Health Cancer Institute.
Hi, Bill Gradisher, professor of medicine and chief of HEMONC at Northwestern University in Chicago.
I am Maxine Jockelson. I'm a breast imager at Memorial Sloan Kettering Cancer Center, professor of radiology, and I also do a little bit of PET.
This is a 41-year-old woman with multicentric right breast clinical T2N1 invasive ductal carcinoma grade 3, ER/PR positive, HER2 negative, treated with neoadjuvant doxorubicin, cyclophosphamide, and paclitaxel, followed by total mastectomy and right sentinel lymph node biopsy. In terms of her presentation, she initially presented with a palpable golf ball-sized mass in her right breast, and she maintains a good performance status, has no medical issues of note, is premenopausal, G3P2, no breastfeeding, used oral contraceptives for 14 years, no history of hormone replacement. She drinks 3 to 4 glasses of wine per month and has no family history of cancer. Going back again to her original screening, her original imaging, the diagnostic mammogram in August of 2020 showed a right breast mass, 2.9 centimeters, with fine pleomorphic calcifications extending to a similar appearing mass with 9 centimeters of distance between these two lesions. The ultrasound confirmed a lesion that was 1 to 2 centimeters from the nipple at 6:30, a 2.3 by 2.3 centimeter mass, and the additional smaller mass at 8 o'clock, 8 to 9 centimeters from the nipple. Also noted was a solitary abnormal right axillary lymph node that was significant in size at 2.5 centimeters. She undergoes a right breast ultrasound guided core biopsy of both the dominant mass and the lymph node, and both reveal grade 3 invasive ductal carcinoma, ER positive, HER2 negative. And she goes on to complete neoadjuvant chemotherapy. Dr. Jockelson, if you could review the mammogram with us.
Sure. So these are 2 views of her right breast, which demonstrate, again, dense breast tissue, and you can see the mass, the index lesion in the lower central portion of the mass, and there is a triangular marker over it, which we use to denote the area of any palpable abnormality. And then the second lesion is not that easy to see on this particular view. You can also see in the right axilla, there is an enlarged node. Now, there is a report that there are fine pleomorphic calcifications, and unfortunately, I was unable to get magnification views to demonstrate that, but that's a really critical finding on patients who are having neoadjuvant chemotherapy, because even if their masses get smaller, the calcs don't necessarily disappear. And sometimes the presence of extensive calcifications increase the extent of surgery, and sometimes patients who would have liked to be conserved may not be able to, because you really do need to remove all the calcifications.
So as stated, she undergoes neoadjuvant anthracycline-based chemotherapy, and then in January of this year, undergoes a preoperative right diagnostic mammogram and right breast ultrasound that does show a response to therapy, in that the dominant mass at 6:30 is now 1.2 centimeters and resolution of a discrete mass at 4 o'clock, and the lymph node also now is 1.9 centimeters, and there is a clip present in that biopsy proven node. In March of 2021, she undergoes a mastectomy and a lymph node excision and a right sentinel lymph node biopsy. There are 3 negative sentinel nodes, one of which does contain the clip. 0.9 centimeters of residual invasive ductal carcinoma is noted at that site where the dominant mass was, ER positive, HER2 negative. 0 of 2 lymph nodes were positive for carcinoma, both with treatment effect, and her residual cancer burden class was 1.
So I think this mammogram, I think, was just her preoperative mammogram. And you can see that the mass that had been seen in the 6 o'clock axis is not well seen at all. So consistent with its decreasing in size. Again, I can't see the calcifications that she had originally. In the axilla, you can see the Q-shaped marker in the axillary node, but it's really hard. There are really no great imaging studies to reliably tell you whether that node still contains any cancer or not. And it's one of these things we talk about incessantly. MR, PET, ultrasound, mammo, all of these things are not accurate enough to determine if the nodes still contain cancer. The other issue of putting the clip in the node is kind of a slightly controversial issue. Some places feel that you have to clip every node. There are data to suggest that even if you don't clip the node, if you actually get 3 sentinel nodes and do dual tracers, you can still get a fairly low false negative rate in your sentinel lymph node biopsies. So different institutions have different policies. We don't clip nodes here. I think most of you probably do at your institutions, but when we looked at our long-term data for locally recurrent tumor, it's no different than the standard at other institutions. So we are happy not clipping them.
So for the purposes of discussion at this institution where this patient was treated, at least 3 sentinel lymph nodes must be evaluated intra-op after neoadjuvant chemo. And if any residual cancer is present, or if less than 3 sentinel nodes are evaluated, a complete axillary lymph node dissection is performed. Due to the discrepancy, the case was further reviewed and only 2 sentinel nodes were removed. Again, one of them did have that clip. So before we get to the question posed on this slide, Dr. Jockelson, I know you mentioned about how it's difficult to have any imaging study definitively tell you about residual disease in the node. But in terms of her initial breast imaging, this is a young patient. She had multicentric disease. It doesn't seem that there was excessively dense breast tissue, but despite that, would there have been any indications to do a breast MRI on this patient up front?
I think if you were going to do a mastectomy anyway, because now whether she's multicentric, I mean, she has a lesion in 6 o'clock and 8 o'clock, so I don't know, but again, I couldn't see how much the calcifications involved other quadrants, but in a patient who's going to have a mastectomy one way or the other, I'm not sure there's great value in doing an MRI. Prior to neoadjuvant chemotherapy. In a patient in whom there is a potential for breast conservation, MRI is the single best way to assess the extent of disease initially, and also to confirm or assess the extent of response. And it's well documented that it's the best of all of our tests. It's still an imperfect way to assess residual active disease within the breast. I think the overall area under the curve, when you look at assessment of response, it's about 70 to 80%. Patients who have more aggressive tumors that are more likely to get a response, MRI is more accurate because the pretest probability is also higher, but we still miss little bits of residual disease. A lot of research is going into looking at radiomics and ways to enhance our ability to assess residual disease on MR. And just a little word, I know at University of Miami, you guys have contrast mammo, and we do a lot of it, and there are some really nice data stating that contrast mammo is equivalent to MR in assessing disease response. And so if a patient can't have an MRI, or depending on the institution, not everybody does MRI for their neo patients. It's a nice way because you actually get the mammogram as part of the contrast mammo. So in one fell swoop, you actually do a vascular study and a mammogram and get a really good assessment of residual disease that is equal to that of MRI in every paper that's been published so far.
Great. Yeah, we're fortunate to have contrast enhanced mammography. Thank you for that information. Now let's turn to how we would handle the axilla in this patient who's had only 2 instead of the 3 planned nodes removed, one of which was the clip node. So we'll discuss axillary lymph node dissection versus radiation. And Dr. Mamanis, I'll start by asking you whether you would offer this patient an axillary dissection.
So the short answer to that is I would not. And let me give you a little bit of the longer answer. So there is the issue of, how accurate the sentinel lymph node biopsies after neoadjuvant chemotherapy is a long-standing one. We have become very comfortable to say that for clinically negative nodes, the false negative rate, if you do it after neoadjuvant chemotherapy, when they started with clinically negative nodes, it's about the same. And several studies and meta-analysis have shown that. For patients that present with positive axillary nodes, biopsy proven, 4 prospective studies showed that the false negative rate was higher in the range of about 12 to 14%. However, during those studies, what became apparent was that if you remove more lymph nodes, particularly more than 2 or more than 3, the false negative rate dropped to single digits, but probably like mid to high single digits, like 5, 6, 8%. And also, if you did immunohistochemistry, actually, you would have decreased it further. But then, as part of these studies, investigators looked at the issue of clipping the node and removing the clip node. And when they did that, the false negative rate was low. In the Z1071, it was, I think, 6.8 if you remove the clip node. But this wasn't sort of planned. This was a retrospective analysis, but it was 19% if you didn't. Subsequently now, MD Anderson data, with taking the clip node out and performing sentinel lymph node biopsy for patients again that present with positive nodes, showed the false negative rate of about 2 to 4%, particularly if you combine the 2 approaches. And more recently in San Antonio, had a prospective study from the Netherlands that showed about a 3% false negative rate when you do the clip node and the sentinel node. Now, the reason for this discrepancy essentially is that when we first started doing sentinel lymph node biopsy after neoadjuvant chemotherapy, 2 questions that became apparent. Is another node becoming the sentinel node in some percentage of patients because the sentinel node is full of tumor and it gets fibrotic? And second is, if that node is negative, should other nodes be negative too? Because these are the 2 different questions. So what became apparent from the data now is that the answer to the first question, does the sentinel, in other words, is another sentinel node take over? The answer is yes. In about 25% of the times, the clip node is not a sentinel node. In other words, the clip node is all full of tumor, becomes fibrotic eventually, could be negative, but then the sentinel node is another one. But it still could be positive, so the false negative rate is higher. But the answer to the second question is, if the clip node is negative, would the other nodes be negative too? In a very high probability, they will be negative, because the false negative rate, if you take the clip node out and the sentinel nodes, it's actually very low. So most people, I believe, feel comfortable not abiding by the 3 lymph node rule removal if you take out the clip node in addition to the sentinel node, the term that MD Anderson coined as a targeted axillary dissection. So this is what we offer to our patients nowadays. If they come in with a positive node and then become clinically negative afterwards, we offer them sentinel lymph node biopsy with lymphatic mapping and then removing the clip node. And by that, we believe the false negative rate is very low, at about 2 to 3%, which I think is lower even than the false negative rate up front when you do sentinel lymph node biopsy on a routine basis. So that's why I would not, in this patient, do an axillary dissection.
Thank you. And Dr. Buchholz, knowing that Dr. Mamanis did not recommend a further axillary dissection, what are your thoughts on axillary radiation in this situation?
Yeah, I think I'd like to first start by talking about just radiation in general. Does she need post-mastectomy radiation or not, which is a relatively controversial topic, or a topic where we have some degree of uncertainty in that decision. As a testimony to that, we have just completed a randomized trial that this patient may have been eligible for, presenting with a clinical stage 2 and then a lymph node negative surgery after the neoadjuvant chemotherapy that would have randomized her to either receive radiation or to not, showing that there is some clinical equipoise about this question of nobody's really certain as to what the right answer is. It is clear that if she were treated with surgery up front, which I don't necessarily recommend, but if she were treated, she would have found to have at least 1 to 3 positive nodes and maybe have 4 more positive nodes. And with a T2 tumor, a high-grade tumor, and a 41-year-old, I think most radiation oncologists would have been compelled to recommend post-mastectomy radiation. We think her prognosis is a little bit better now because she's shown that her disease responded favorably and became lymph node negative after neoadjuvant chemotherapy. So her risk of a local regional recurrence is probably lower than we would have originally estimated before we knew the chemotherapy response. But given her age and the tumor size and the grade, I think off protocols, now that the protocol is closed, I would be swayed to discuss with her, and if she said, what would you recommend? I would say, yes, I think we should consider post-mastectomy radiation for her. And then the next question is, what do we target? Well, when we treat post-mastectomy radiation, we tend to treat comprehensively. And so we would be including the chest wall. We would be including the internal mammary lymph nodes. Having a 6 o'clock tumor, if you look at intratumoral lymphoscintigraphy, we published data on this. Those not infrequently have dual drainage to both the internal mammary lymph node chain and the axilla in that tumor location. So we'd be targeting the upper 3 internal mammary lymph nodes, and then we would be targeting the supraclavicular axillary apex. But because she hasn't had a lymph node dissection, we would go ahead. It doesn't make sense to treat the level 3 axilla and not treat the level 1-2 axilla. And so it's very important that we use modern radiation tools like contouring the structures with CT treatment planning to assure that we conform the dose, and we routinely contour the axilla levels 1 through 3, the supraclavicular fossa, and the upper 3 interspaces of the internal mammary lymph node chain. I think the treatments can be delivered quite safely. We would treat post-mastectomy radiation usually with a 5 to 6 week treatment course. I'm not feel compelled to treat her for 6 weeks with a boost because of her favorable disease response. And I think she would tolerate it well. The biggest potential consequence would be the interaction between radiation and whether or not she had a reconstruction.
And given the fact that this patient had a right-sided tumor and was young, I'll ask you, in the situation where she was older or the tumor was left-sided, would that influence any of the recommendations that you just detailed?
There are some characteristics. For instance, if she was older and had T1 with an N1 disease and had a pathologic complete response, I would guess her risk of local regional recurrence may be low enough that it'd be reasonable to not consider using radiation at all. The left side, I think you mentioned in light of weighing out the risks and benefits with radiation and the potential cardiotoxicity of radiation. I think we've been able to overcome many of the historical cardiotoxicities. We now have newer techniques that can displace the heart from the radiation field. It sounds kind of barbaric. I joke with the patients, I say, we're going to grab your heart and pull it away from the chest wall, and they feel a little fear. But then when we explain you do that by use of their diaphragm and just having them take a deep inspiratory breath hold, that actually displaces the heart quite dramatically from the targeted areas of the radiation field. And so we really limit the amount of radiation that goes to the heart, even in left-sided cases to date. So I think we could give it safely, whether it's left-sided or right-sided.
Thank you. Turning to systemic therapy considerations in this patient who received neoadjuvant chemotherapy, and it's somewhat expected to not see a path-CR in ER-positive, HER2-negative disease. Dr. Gradishar, I'll ask you, how are we viewing the presence of residual disease in this young woman as far as how it impacts her risk of recurrence, and how does this influence the adjuvant therapy, both hormonal and perhaps the use of a CDK inhibitor in this situation?
Sure. So I think, as already pointed out by others, the response has been pretty good. I mean, the patient had resolution of her lymph nodes. She does have some residual disease at the time of surgery in her breast, but it's very modest, as you pointed out. So I think her prognosis is generally good. If she had absolutely nothing, a PCR, it would potentially be a little bit better. But I think at the outset, you said we don't necessarily expect a PCR in ER positive disease. And I think that's what we're seeing here, but she's had a very good response. So all that said, we often now focus on these patients with residual disease. And where we've been guided by clinical trial data is more in patients with either triple negative breast cancer or in those with HER2 positive breast cancer, where we modify our treatment recommendations accordingly. So TDM1 for HER2 positive disease with residual disease. And in triple negative breast cancer, we may consider capecitabine or any of a number of clinical trials. But in ER positive disease, I think in this setting, the standard still remains to give her endocrine therapy. And I wouldn't necessarily recommend any additional chemotherapy for her. And then the question comes up based on data in high-risk post-surgical patients, the monarchE trial, where there was some indication with early data, or early follow-up, I should say, that there may be an advantage downstream by adding a CDK4/6 inhibitor to endocrine therapy. Would one apply that same observation to a patient like this? And I would say at this time, we don't have sufficient data to recommend that. I would not do that. We have some data from trials that have looked at palbociclib in patients with residual disease at the time of surgery. And there was no indication that the addition of a CDK4/6 inhibitor postoperatively conferred any additional benefit. So I would, as they say, keep my powder dry and not use that at this time until we have data that really indicates that you're adding something.
Thank you. And before we move off this case, I'll ask the panel, based on her young age and no family history, would anyone feel strongly about offering this patient genetic testing? Dr. Jockelson, I see you nodding.
41-year-old woman with the bad breast cancer. Yeah.
Okay. Okay.
If I can ask the question, Bill, would you give ovarian ablation to a patient like this?
Well, I think that would be a consideration. I mean, if we go by text and soft and just very crudely say, where was the benefit seen? It was in younger patients than 41. But we also know that when a step analysis was done of that data, if you take into account the baseline risk, you can identify patients who may still gain benefit from ovarian suppression. So I think it would be a discussion with her. It may add some additional benefit. So one would have to weigh the pluses and minuses. Obviously, you're rendering her postmenopausal probably a decade earlier than she was destined to become so. And of course, we also have to see if her menstrual function or ovarian function returns after receiving chemotherapy.
Does anyone have any further comments on this case? Okay, in light of that, I'll just summarize. So the panel concludes in this case, the recommendation is no axillary lymph node dissection. Post-mastectomy radiation is recommended, and the target would be comprehensive and involving those areas that Dr. Buchholz detailed. Endocrine therapy with a consideration for ovarian suppression. And although certainly a discussion of the adjuvant CDK4/6 inhibitor data would be reasonable, this isn't something that would be routinely recommended at this point.